Hi, good afternoon, everyone. The title of our group's research is Occupational Therapy Students' Perceptions of Cultural Competency and Chinese Culture and Implication for Education. My name is Kelly, and my fellow group members are Elizabeth, Jenny, and Justine, and we're led by our faculty advisor, Dr. Vikram Pagpatan, who helped us along with our research and provided plenty of guidance and feedback throughout this time. So to start, during our research, we're going to be referencing the term cultural competency a lot, so I thought we could start with defining what this means. According to research from Nair and Editayo, cultural competency in the context of healthcare refers to a provider's ability to interact and collaborate with individuals from different cultures, which in turn impacts patient outcomes and healthcare experiences. As ethnic and racial minority populations grow, underrepresentation of these groups in regards to cultural competency in healthcare is still underrepresented in research. In this research study, we sought to find where OT curricula for an MSOT program could be evaluated and potentially enriched to provide culturally competent care for people of Chinese descent in particular. This is relevant as these groups continue growing as well, and lacking areas of research can negatively affect the overall quality of life and health of these groups. In the US, it's a culturally diverse nation with Asian American and Pacific Islander communities, AAPI communities, representing the fastest growing racial and ethnic groups. Asians account for 5.8% of the national population, with Chinese Americans being the largest of these subgroups. People of Chinese descent make up this largest Asian ethnic group, yet are not individually represented in research. Here, there is an opportunity for OT curricula to be evaluated and enriched by including education on providing culturally competent care. Providing culturally competent care will result in improved patient outcomes and their overall experiences with their healthcare providers in turn. Research has shown that Asian American patients experience less improvement in functional outcomes in home healthcare, potentially due to culturally insensitive interventions, especially in activities of daily living and instrumental ADLs. In Western OT practices, these cultural roles are often overlooked as varying from Eastern practices of medicine, such as caregiving, language barriers, and other factors such as education status, family dynamics, and spirituality, which all end up influencing rehabilitative outcomes. There is not a single approach to developing cultural competency for all cultures, but the healthcare field has the opportunity to address healthcare disparities across various races and ethnicities, utilizing educational outcomes to promote inclusive care. Occupational therapists in particular value delivering culturally relevant care, yet current OT education has shown a lack of sufficient training on cultural competence specific to AAPI and Chinese populations. This gap contributes to inadequate care and poorer outcomes, and frameworks for cultural competency exist in OT curricula. Their application remains to be seen as challenging due to the vast diversity among different cultures. So our research question is, where can OT curricula be enriched? Where can OT curricula be enriched by including education on culturally competent care? A gap in literature we acknowledged was the lack of OT-focused studies on treating the AAPI populations, specifically Chinese populations, and further, the lack of studies evaluating the efficacy of MSOT curricula on developing cultural competence. The evaluation of such topics allows insight into OT practices to facilitate greater cultural competence, which may be generalized to the overall healthcare field.
So for our study, we utilized a mixed methods design, and we incorporated a survey for quantitative data collection and focus groups for qualitative data. We used a convenience sample of 12 students from an accredited MSOT program in the northeastern US region, and they were recruited through email. Eligible participants included MSOT students currently matriculated in an accredited program in the Northeast region or alumni at the program at the time of the study. Participants signed up through Google Forms, answering questions about scheduling availability. With this, 3 focus groups with 4 participants each were set up based on participant and researcher availability. These focus groups were conducted virtually through Zoom. The first two groups consisted of 2 first-year and 2 second-year MSOT students. The third focus group consisted of 3 third-year students and 1 alumni. Researcher roles included a moderator, timekeeper, transcriptionist, and tech control for each focus group. By conducting focus groups, researchers were able to perform real-time comparisons of responses provided by participants. A consent form and survey through Google Forms were provided to participants at the start of their designated session. The survey collected general information, including age group range in years, schooling year within the MSOT program, educational background, healthcare exposure, experience working with clients of Asian descent, and location of upbringing. Any identifying information, such as gender and race, were omitted. 6 questions were asked to each participant individually, with 1 minute and 30 seconds allotted per person to respond. Questions were displayed on the screen for participants to read along, while the moderator read each question aloud prior to the start of the first participant's response time. Participants were called on to answer in a specific order, which was reversed halfway through to mitigate response bias and maintain equity of process time for participants. So the moderator asked questions and remained hidden to prevent observer bias. The timekeeper notified participants when 30 seconds were remaining and when their time was up. The transcriptionist provided real-time transcription of responses, and the tech control handled any technological concerns within the Zoom call. We also utilized Otter, a transcription software, to assist with transcription of the qualitative responses. And as the researchers, we manually coded generated transcripts and categorized similar codes to form a collection of commonly discussed topics. Interpretation of the topics produced a narrative analysis of MSOT students and alumni perspectives of their program and how well prepared they felt to provide culturally competent care to clients of Chinese descent. The quantitative responses from the survey were organized into bar graphs and pie charts, which will be seen on our poster.
So for our results, thematic analysis of focus group interviews yielded several themes and actionable suggestions with implications for MSOT curricula and cultural competency education. The first of which being factors influencing perceived self-efficacy for treating Chinese clients. Participants identified language barriers as a factor negatively impacting self-efficacy. They expressed a mixed reliance on translation apps and language interpreters, with some acknowledging that information can be lost in translation with software and preferring live interpreters such as colleagues instead. Factors positively impacting self-efficacy were found when participants shared cultural similarities with their clients, such as shared religious beliefs, child-rearing practices, collectivist views, and family-oriented values. In addition, another positive factor was personal experiences with Chinese culture outside of formal educational opportunities. The next theme yielded was nuances in cultural competency education, serving as a barrier to implementing practical solutions. Participants rightfully acknowledged that although it is important to be aware of a client's culture, it might not be an aspect of their identity that impacts daily occupations. Instead, there was an advocacy for universal respect, open-mindedness, and genuine interest when interacting with all patients. Inconsistencies in experiential learning opportunities was another theme brought up by participants. When participants were asked about their opportunities for a hands-on experience working with clients of Chinese descent, there were varied responses. Participants had mixed responses on the provision of experiential learning, such as service projects in the community and fieldwork placements. Many mentioned varied and inconsistent opportunities depending on location and demographic of fieldwork sites. And lastly, participants suggested several potential solutions for improving cultural competency education. For instance, participants expressed interest in hosting guest speakers from different cultural backgrounds, practice settings, and communities. Participants also called on faculty to share their experiences treating diverse communities, as well as their personal experiences strengthening their cultural competency skills. Other suggestions include the incorporation of culturally relevant projects into coursework, utilization of case studies to facilitate classroom discussion, as well as a dedicated course on cultural competency. So to summarize, this pilot study found that instructional learning within the selected MSOT program addressed the general scope of cultural competency but lacked hands-on experiences and culture-specific training for students. We found overall feelings of inadequate preparation to provide cultural competent care to clients of Chinese descent, with first-year students reporting a lack of exposure thus far in their curricula, with any cultural awareness credited to past experiences. They did, however, express enthusiasm for future experiential opportunities. And for students further along in their academic and professional journey, they emphasized benefits of experiential learning but highlighted a disparity in these opportunities. These students recommended diversification of learning through guest speakers, modules, events, and focused resources to supplement inconsistent learning opportunities. And for the limitations of our study, the goal of this pilot study was to interview 4 members from each representative participant group. However, this was not attained due to scheduling conflicts and project time constraints. Of the 12 participants recruited for the study, we had a 100% response rate from first and second years, a 75% response rate from third years, and a 25% response rate from alumni. As a result, responses from this alumni were discussed but are not representative of the population due to the disproportionate sample size. Future research should be conducted with proportionate and larger sample sizes to better represent target populations. Furthermore, as a result of the convenient sampling from a singular MSOT program in the Northeast region of the U.S., study results may not be generalizable to other regions or other MSOT programs.
So in conclusion, participants expressed that there's an opportunity to improve preparation of MSOT students to providing culturally competent care, and these measures of successful health outcomes in the scope of OT include increased adherence to therapy and home programs, independence in ADLs and IADLs, and the quality of life. There are implications that programs outside the Northeast region with less access to diverse communities are disadvantaged to provide culturally competent education. Again, this study was conducted in a Northeast region where New York City and Boston are 2 of the cities with the largest Chinese population. So this would indicate that programs outside of the Northeast region with even less access would not be as equipped to providing this culturally competent education. So there's further research needed to explore these implications and generalize findings to broader cultural populations and programs. And participants also expressed that additional exposure and experiential learning opportunities could be incorporated into the programs to develop culturally competency skills to increase compliance with ACODE standards on foundational content for students. So our references are available in this QR code for those interested to scan. It will also be available on our poster. Do we have any questions? Okay. And then lastly, we'd just like to express our thanks. So thank you to our advisor, Dr. Pagpatan, for his guidance throughout the master's project sequence, SUNY Downstate Health Sciences University, and all of our focus group participants.